Okay, also guten Morgen alle zusammen zum BALT Symposium. Ich darf vorweg schicken, dass wir die Sitzung auf Englisch machen, weil wir doch relativ viele internationale Gäste haben. So, good morning everybody to the BALT Symposium on Bifurcation Aneurysms. We will do the session in English since we have many international guests as well. You all probably know that BALT is a very diversified provider of devices for aneurysm therapy, especially bifurcation aneurysms, providing a large portfolio and a complete set of solutions ranging from balloons to stents to intrasaccular flow diversion, and also providing the eclipse device. And BALT put together, I think, a very complete program. Experienced users and experts in that field, and since BALT put also together a very tight schedule, we immediately start with the first presentation. René Chapot from Essen will present his experience on remodeling using the eclipse 2L and stent-through-baloon-technique. So René, I think you're already with us, and good morning. And
absolutely.
Enjoy.
Good morning. It's a pleasure to take part and to be able to present here. I guess I can now open my presentation. Here we are. So why to use remodeling balloons? For many reasons, because the results in the literature show that all overuse is steadily increasing with time, even if balloons are just used as sentinel, just in case you may need it, but not always necessarily. With different papers showing that the rate of occlusion obtained, but also the risk of complications is reduced when handling balloons, as in the Athena study. In my opinion, here are the main landmarks why to use a balloon, because it's the best way to understand what you do. And if an aneurysm is always drawn like this with the neck, which is here, and the part to coil is here, this only gives a partial understanding of what's going on. Because if you look somehow on the lateral view of the aneurysm might look like this with the artery here. So the view we had on the AP would occlude this, but you see obviously that this part here in light gray would not be treated. And this is something that you can see with the balloon. So this kind of dynamic imaging when coiling is already partially achieved, which may show some superimposition between coils and balloons as soon as some rotation of the angiosystem is being done. You may guess whether coils are indeed in the artery or just working projection is wrong. And I think that despite the quality of the angiosystems today, there are still many situations where this may occur. And understanding of anatomy may be very simple, but sometimes it's not. And this ACOM aneurysm just is complicated to understand, and it's just the double axial view, let's call it like this, image on the right that enables to understand what's going on, or having a situation where the working projection is not accessible. You may see here the first picture on the left that we have a red symbol because it's not possible to have X-rays from the bottom to the top of the head. And how to understand this aneurysm? If devices are inside, you may understand what's missing here. You see this recanalization that then was treated. So understanding is a key point. Control of bleeding is luckily something that does not occur too often, but if it happens, to help yourself, the best way is to temporarily stop it by having something in place. This is what I just mentioned before as sentinel use, but also other situations such as stabilization of microcatheter. And aneurysms, we don't talk about the easy ones, but let's look at some challenging ones where the neck is not so small, the aneurysm is implanted at the origin of A1 of this carotid T, like quite usual, and the point is not only to stabilize any device inside, but also to have a catheter somehow not displacing too much and not bumping on the bottom of the aneurysm. And if different devices and balloons are placed, then both balloons will keep the microcatheter just in the middle of the balloon, and this enables usually to properly coil the aneurysm. And you see here that also baby Leo in half T position was placed in A1. And one of the major advantage I consider today when handling balloons is, since we have the double lumen balloons, and one of the best ones is the eCLIPse 2L, which is available in different sizes and which is highly compliant, so the risk of injuring the artery is very low, then you can use this technique that is very important in our practice for unruptured aneurysms, which is a stent-through-balloon technique, where, such as this pericallosal, of course, there are many ways to treat this aneurysm, but if you balloon assist coil it, the level of safety will be very high, keeping the catheter at the neck. And once the aneurysm is coiled, you see during coiling, step in and out of the aneurysm as much as you want. And after coiling, you can place through the balloon a small braided stent. And our preferential use, and this is what Professor Dörfler is going to explain to us more in detail about the positive advanced qualities of the baby Leo. Here it has been placed in the pericallosal. You can even use the balloon to be sure that you got a proper wall position. This is immediate results. You see that after follow-up, the little baby aneurysm that was associated has shrunk significantly. So why to do like this? There may be different reasons. One of the reasons is that it's not always so easy to know in advance which artery should be stented. And if the neck is large, extending on both arteries, it sometimes appears that the artery which is stented is not the one that you initially intended, just because there is missing coil stability, or finally the artery needing protection is not the one that we thought could be. Another major reason to do so is that one of the worst situations in our practice is when we are facing a complication, which is patient having a stent implanted, where you need a dual antiaggregation. And simultaneously, this patient has some bleeding because of some distal wire perforation or any other cause. And this is very tricky and difficult situation where whatever you do, you get into the risk of having further complication. And that's why, if stenting is only intended in order to stabilize the treatment, then it's possible after balloon remodeling to do a dyna CT, a sine spin CT, for instance, where you can check whether there is a bleeding and only place a stent once you're sure. And this is a recent example. This aneurysm was balloon remodeled and we were about to place a stent, but then we made a sine spin, saw a little bit of blood, checked again our pictures, recognized here, you can see on the right picture, this is a little bit of bleeding that we did not see before. And then, of course, we did not place a stent. We reversed the antiaggregation, and the patient had no issue, which may otherwise have been the case. And of course, we have different patterns of stenting. Regular stenting is the way we place usually stents from distal to proximal to the aneurysm. Why stenting? We all know what it is. T-stenting is something which I think is very appropriate with braided stents and with the baby Leo or half T, as such situations where there is no good treatment or no ideal way to stent here, because a flow diverter maybe, but we take some risk on other arteries that will be bridged. Placing a stent from the PCA to the basilar does not protect the SCA, which is the most compromised artery. And the best way is to stent here the SCA, but while doing so, placing from SCA to basilar would make a U-turn, which is not favorable. And here, by doing dual balloon remodeling, coiling, and placing the stent as half T, which means the stent just goes up to the origin of the basilar and not any further. This is our way to proceed and to obtain a very high stability that we don't have. So last slide, the technique is being used very often, and I want to show this, that the stability of occlusion is, it enables to treat a lot of aneurysms, and it's rare that this technique does not enable to do so. So no limitation in the indication to treat, thanks to balloon remodeling, with very high occlusion rates, and the follow-up that is available for a high number of patients. We're working on it to get this figure better, is still with a Remodeling scale of 1 in 90% of these aneurysms. So I think that this combination is very helpful, and I will stop my presentation to allow the symposium to stay in time. Thank you.
Okay, René, thank you very much. Very impressive results. I forgot to say that there is a chat function, so if you have questions, please feel free to insert them in the chat, and then we try to pick at least one after each presentation. Thanks again, René. There is no question up to now, and I think we move on with the presentation on the Leo baby, which is done by myself. So, as you see, for wide-necked aneurysms, easy, safe, and durable. Okay, here is the presentation. So, very quickly to the stent, as René said, it's a braided stent. It's a nitinol self-expandable stent. Nitinol provides a very good memory effect. Due to the braided technology, it's resheathable. And it's indeed very easy resheathable, up to 90% of the stent length. And René knows this very well. If he does T-stenting, of course, he has to resheath sometimes to put the stent in a proper position. And it's very good visible due to helical markers over the whole length of the stent. And importantly, it goes through a 10 microcatheter Vasco plus 10 ideally. The large size portfolio you can see here, and this is only the Leo baby. You know that there is a Leo stent available as well for the larger diameters. So the artery diameters range from very small 1.5 up to 3.6, and the length is up to 35 millimeters. You see here a case as introduction, a broad-based ACOM aneurysm, and you see that we preferentially use a trailing technique. This is the recommended technique as well for this stent. You see here that the Leo baby has an own guide wire, which provides very good tracking and navigation. And you see that there is usually an excellent remodeling of the aneurysm base as well. And this deployment is really very easy. So compared to flow diverters, it's much more easy. You can just unsheath the stent, as you can see here on this drawing. And again, this guide wire, the own guide wire of the stent, provides a very good support and navigation. And you see this here again in a trailing case. You see here the stent already in place. Usually we start more distally and then we pull the stent in the proper position and open the stent very easily, as you can see here. Here a bifurcation MCA aneurysm, broad base, and also treated with a trailing technique. And you see that the stent very well adapts the anatomy. There's a very good Waller position of the stent due to the radial force. And this is a follow-up already. And I think we can confirm the impressive series of René's institution that the follow-up results are very durable, very stable. We rarely never see recanalization with a stent-assisted coiling. So this is another advantage. René did not mention that the results are very durable and that we realize very rare cases of recanalization. And this is another case, a more complex MCA bifurcation aneurysm. and on the other side as well, a tiny MCA aneurysm. So you see here the right side treated with stent. Here is the stent already placed, and then you can easily pack this aneurysm. You can fully pack. It's not always necessary to completely pack this aneurysm due to this flow diverting effect of the Leo baby as well. And this is the other side, looking quite easy for a simple coiling. But then it turned out that it's not so small-necked, and you see that there is a Leo baby in place as well. And this is the follow-up after 2 years, and you see a very stable result. Another case, complex ACOM with a hypoplastic A1 on the right side. You see that there we put 2 stents, one in another, so that we have an overlapping here at the neck. This was at a very early case when we had not available the longest length of the stent. We would now choose probably a much shorter stent, but you see that this is the result, and this is the follow-up, so that there is even more occlusion. So this is considered completely occluded, but you see that there is no more inflow in the follow-up. So again, a very stable result. And as René said, for the complex or very broad-based aneurysms incorporating such as this aneurysm, both P1 segments, you can use this stent also very nicely in an T-stenting technique. So we do not prefer the Y technique, but the T-stenting is very easy possible due to this resheathable stent. So then you can exactly place the stent. And if it's too long or does not fit, you resheath it, go more distal, and then detach or fully open it if you are in the proper position, as you can see here, the final result here. And this is the follow-up here even after 4 years. So we have also many data on 4 years with a very stable results. And then you might know cases where you have recanalizations after coil embolization or other devices. As you can see here, this is also a complex MCA aneurysm. It had been a complex aneurysm up front, presenting with a subarachnoid hemorrhage. So initially completely occluded with an intrasaccular device, the web, as you can see here, but then recanalized. And for those cases, the Leo baby is also a very definite treatment. It's easy sometimes, or it's more easy to catheterize the superior branch because you can push against the web very easily. And you see here the final result, which is also very stable over time. So this is adds or expands our portfolio also for these cases. And René showed this pericalosa aneurysm with that tiny additional aneurysm, which was completely occluded just by the Leo baby stent over time. This is a more fusiform aneurysm, larger, but this is treated only with a Leo baby stent. So there is a considerable flow diversion effect of this stent as well. We know this from the Leo for years, and actually it's a flow diverter also. When we look at the density of the struts and of the meshes, it could be easily named a flow diverter. It's not named a flow diverter, but you see here that there is a really significant flow diversion effect as well. Which again adds the good results during follow-up. This is not so impressive as René's series. This is our series on at least what we published on the follow-up. So we had a high initial occlusion rate, as you can see here, but also during follow-up we have a very high and still progressive occlusion rate, like for flow diverters as well, of more than 90%. This is according to René's results as well. We have a low complication rate. So overall, this is a very good device. Stent, as safe, as stated on the initial slide, durable and easy to use. So this is also the take-home point for this presentation. I think we should take in mind that there are progressive occlusion rates and that there is a flow diversion effect. So it's not always necessary to densely pack the aneurysms when you combine it with a Leo baby. Okay, so I think we move on to the next speaker. I still do not see any question in the chat. So we are still perfect in time. And it's my pleasure to hand over to Thomas Liebig from Munich, who will present, I think, very early results of the intrasaccular device, the contour system, which again expands the BALT portfolio in bifurcation aneurysms. And Thomas, feel free.
Thank you very much, Arnd. Good morning, everybody. Intrasaccular flow diversion with contour. Okay, just a brief comment why this is an important topic. This presentation, this publication, I'm sorry, which was done in the preparation of the WEBIT trial, has analyzed any publications from 2000 onward to 2016 on white neck bifurcation aneurysms, showing that those are especially difficult to treat, which is illustrated in the numbers down here, because what they found was that overall the rate of adequate or complete occlusion was rather lower than what most of us think. At the same time, in those studies, the safety endpoint was met in a relevant number of cases, meaning there is also a certain risk when using all kinds of devices to address this special entity. In other words, white neck bifurcation aneurysms before the advent of intrasaccular devices represented sort of an unmet medical need. The contour intraaneurysmal flow disruptor is an intrasaccular device. It consists of a double layer of 144 drawn-filled tube wires, which have the greatest density at the marker in the middle. It's detached electrolytically, has one marker. Because of the DFT, it is completely visible under fluoroscopy. And the current system, except for the two largest versions of 11 and 14 millimeter, is 21 microcatheter compatible. When it's deployed through the microcatheter, it opens immediately, which is a nice and important feature, as we will see in some of the following cases. The two layers might separate before it's completely open. And then once it is open, it adheres fairly well to the aneurysm wall, which you can see by the fact that it's not moving upon distribution wire or delivery wire push and pull in this silicon tube here. With the web, we already have an established intrasaccular device. So one question could be, what's the difference? The main difference, I think, is that other than the web, we are not dealing with a volumetric approach to fill the aneurysm, but rather a semi-2D approach that concentrates on the neck only, very much like intra-arterial flow diverters, which means it is not immune, but less prone to difficulties depending on the actual aneurysm shape, since we're only dealing with the neck. Another important difference is that the effective working length in the catheter, if we look at web and contour with the aim of similar sized aneurysms, the contour, because it's much less material, is much shorter, which means that you don't have to move the microcatheter as much to deploy the implant in the aneurysm. And this can be helpful in some difficult situations like this Suka aneurysm, where in order to place the implant, the microcatheter would have to be withdrawn from the aneurysm, which would potentially mean that you could lose your position and have to reintroduce a microwire to reobtain the position. This treatment was rather easy and finished in 12 minutes total, and I think it's a nice case for contour. Also, aneurysms that have an aspect ratio of less than 1, meaning they are very shallow or they have, so to speak, no neck at all, can be addressed with the contour as long as the contour is able to hold on to the outer rim of the aneurysm neck, as you can see in this extremely shallow basilar tip aneurysm here. Because of its construction, it has a relatively large freedom of rotation, because if you think about it, just 1/2 of the implant would be sufficient to cover the neck. So if we rotate the situation by 90 degrees, this would still mean that we can potentially achieve sufficient coverage of the neck. This is a case that I had shown previously where it was not possible to place the web as planned because of its length inside the microcatheter and because of the angulation of the aneurysm. The web straightened the microcatheter, and in the end, I had to use a contour which sort of self-positioned in the right spot to occlude the aneurysm here. Another option, it can be used with coils, or if you need to do so with stents as well. This case shows that a large contour was placed at the base of the aneurysm with a microcatheter jailed inside the aneurysm, and the contour then prevented any coil protrusion into the parent artery without the need of a stent in the parent artery. In Munich so far, we have treated 34 aneurysms with contour. The majority were actually wide neck bifurcation aneurysms, and 9 of those aneurysms were treated inside the trial that was done with the device. By now, not only wide neck bifurcation aneurysms, but also small, rather distal sidewall, large and giant aneurysms have been addressed with the system. Here's an example. This was also the first case that went into the study. Large basilar tip aneurysm with these satellite outpouchings at the dome. The microcatheter during delivery of the contour had sort of self-centered, meaning the marker of the contour is completely eccentric with regard to the aneurysm neck. We saw immediate stasis and flow reduction after detachment, as can be seen here. And in the 6-month follow-up, it was a very good result. The fact that we see contrast beyond the device here is due to the fact that the device is in the anterior part of the neck, and most of this contrast is actually behind the implant. The study was a prospective multi-center trial on safety and performance conducted in Denmark, Germany, and Austria. This is the distribution of the aneurysms. Majority were ACOM, MCA, bifurcation, and basilar tip aneurysms, and the usual parameters for safety and efficacy were looked at. The majority were actually wide neck bifurcation aneurysms, meaning their neck width was more than 4 millimeters. The mean neck width of all aneurysms was 4.3. Once more, you see the distribution here, and the devices that were used were distributed like this, with the 7 and 9 millimeter being the most frequently used. Aneurysm occlusion at 6 and 12 months was satisfying. I should say it was rather good. The overall rate of adequate occlusion, meaning Raymond-Roy 1 and 2, was reaching 90% at 12 months, or at the last follow-up available, which was used because the study was conducted at the height of the COVID pandemic, so many patients refused to come back at their scheduled follow-up time point. With a combination of with the combination of 6 and 12 months, and in comparison to previously available studies on intrasaccular devices, again, the results look rather promising. these are only 30 patients admittedly, but the rate of complete occlusion is especially promising because this reached 73%. And it's also interesting that there was a high rate of progressive occlusion between 6 and 12 months, which means that we probably see more of the flow diverter effect with contour when compared with the three-dimensional intrasaccular flow disruptors that we know previously. So to conclude, I really think the device has game-changing potential. White neck bifurcation aneurysms are indeed the prime indication, but it can be applied to any kind of aneurysms. Size limitations will always exist. By now, the largest available size is 14 millimeter, which means that we can treat contour-only aneurysms about 10 to 12 millimeter diameter maximum. With the experience so far, which, like I said, is limited, we can probably expect 80+% adequate long-term occlusion. And again, in the CERES trial, these numbers look very good, but of course they have to stand the test of time to see if this is also true in larger series. Thank you very much. I hope I stayed in time and be willing to take your questions later.
Yes, you perfectly stayed in time. Thank you, Thomas. Very interesting device and promising results. I think it's still a limited number, but based on your experience, when you talked about this rotational aspect, initially I thought this is a disadvantage, but when I follow your presentation, you think this is more an advantage because you might treat easily aneurysms which are probably not suited for other devices. Is that the case?
With the experience so far, I really think that is the case, because if you think about it, it's like a globe that is cut in half. So independent of its actual position with regard to the aneurysm, it always leaves a sort of rounded shape at the level of the neck. So it doesn't matter as much in which way it is rotated. So in this case, that couldn't be treated with a web. It was super easy to put the contour. The marker became to lie completely eccentric, but it didn't matter with regard to the aneurysms. Aneurysms that have a very shallow bottom where you want to recreate like a straight neck, this is more difficult, and those I think are actually more suitable to be treated with web.
And the majority has been treated with a contour only or in combination with coils?
In the study, they were all contour only. In my personal series, I have treated, I don't know the exact number, but probably 4 or 5 in conjunction with coils, usually the very large ones that have been pre-coiled and had a recurrence.
And you have to jail, and you cannot go afterwards through any strut or slot or whatever.
You won't go through the struts, but I have learned that it is, of course, preferable to jail, but if you lose your position and you re-enter the microcatheter, the device is soft enough to give it some space to slip between contour and the aneurysm wall. So you don't need to jail, actually, but you won't go through the struts.
Okay. This is probably not in the IFU, but it works, as you say.
Yes.
Okay, so thanks again, Thomas, and good morning to Denmark, Aarhus. I would like to introduce Dr. Leif Sørensen, who will present the results on the eclipse, so coming from intrasaccular now to outside the aneurysm. More or less same principle, I think, outside, and we are looking forward to hear your presentation. Please, Dr. Sørensen.
And I will talk about the eclipse experience in bifurcation aneurysms. My disclosures. As we have seen in the previous talks here, there is often need for adjunctive devices, and there also a greater risk of recurrence when treating bifurcation aneurysms, especially those ones with a low dome to neck ratio and a low aspects ratio. It has been shown by our colleagues here that you often need an adjunctive device of some sort here. And the risk for recurrence is also increased if you have a low dome to neck ratio and a low aspects ratio. And this is, of course, because of this water hammer effect, which tends to compress coils or intrasaccular devices over time. There's different devices on the market to help us treat these difficult aneurysms. We have the web and the contour that we have heard about now. We also have seen the pulse rider. We have the P-conus, the P-canvas, and here we have the ecLIP, which is a device used outside the aneurysm as mentioned. And this is the one we're going to talk about today. The eCLIPs is a non-tubular implant. It can be detached electrically here. It comes with a delivery wire attached to the clip. It can be shaped, and we can use it to facilitate the placement of the eCLIP, as we can use this delivery wire as a microguide wire. It is intended for treating aneurysms at the carotid and basilar terminus, and it gives a complete coverage of the bifurcation neck. It gives a good and effective coil retention and achieve a good occlusion. And on top of that, we have a significant flow diversion effect. It's a self-aligning design, meaning that when you are unsheathing it, it tends to align with the spine of the eCLIP against the aneurysm neck, and it tends to rotate correctly, so it will cover the neck optimally. The new versions of the stent is compatible with the microcatheters in 021 and 027-inch microcatheters. It is fully retractable and can be repositioned before detachment. And as we know from other stents, we have some problems with foreshortening, which we don't have in this with this device. It's a stable stent. When it's deployed in the vessel, we have the anchor segment here, which gives good stability and prevents migration. The leaf segment here is the one that's covering the aneurysm neck, and it gives, as mentioned, both fly diversion and coil support. The eCLIP technique is shown here. When we have a bifurcation aneurysm, we tend to go to the branch that is anticipated to be the most difficult one first, out with the microguide wire and in with the eCLIP. And when it's unsheathed here, we pull it a little down, and then with the pusher wire and the microcatheter, it's directed to the second branch, and we push it gently across the aneurysm neck. And when the distal marker here is in a safe position, we can detach the eCLIP, and then we can enter a microcatheter through the leaf segment, and then we can coil the aneurysm. The new portfolio of eCLIPs is shown here. They are both fully electrical, detachable, and the standard one here is meant for coil retention, but as mentioned, it also provides flow diversion, and it comes now in 4 different sizes. A small one here for the small necks fit in a 21 catheter, and the other 3 here, which goes up to a neck width of up to 12 millimeters and a neck depth of close to 6 millimeters. The 3 last ones here will fit in a 27 catheter. And the latest member of the group here is the eCLIP meant for flow diversion called EBFD, and it has more metal in it, and it gives significant more flow diversion. But it, of course, also allows us to put a microcatheter through the leaves and add coils if needed. The functional effect is that we block the water hammer effect, as shown here in this clinical case. It's a basilar tip aneurysm before placing the eCLIP, and immediately after we see significant flow diversion with stagnation of contrast medium in the aneurysm. And coil retention, and it also gives a platform for endothelial growth, and we don't impede access to the side branches. Some clinical examples here. This is a carotid tip aneurysm in a patient who had another one on the other side, which has bled 6 months earlier. So we want to treat this one on the right side. Here we see the eCLIP in place with the anchor segment here, the leaf segment here, and the aneurysm and aneurysm neck here. Seen in the axial projection, we see here that the rotation is optimal, covering the aneurysm neck very well. And we have flow diversion immediately after this one. Actually, this case is the first we treated with the flow diversion model here, but we added some coils here just to be sure it would close completely. And we see here we achieve a good occlusion. The other one is basilar tip aneurysm. It came 1 year earlier and was treated with a web device. At first follow-up, we saw this recurrence, which we want to treat it. We put an eCLIP here. As you can see here on the 3D image, we have the leaf segment here and the anchor segment here. And it also here gave a good flow diversion, but we added coils. After 1 year follow-up, we have this image here. And it was completely occluded, Raymond Roy of 1. And 3 years later, it looked like this, stable and with patient arteries. Medication and tools, we use standard double antiplatelet therapy starting 5 days before the operation with aspirin 75 milligrams twice daily and clopidogrel 75 milligrams once daily. If the patient is resistant to this, we use Brilic or ticagrelor with 90 milligrams twice daily. During the operation, we add heparin, aiming at a baseline ACT of three times the baseline value. After the operation, we continue with aspirin for 6 months and clopidogrel for 3 months. We use standard guiding catheters, for instance, Neuron Max or the Therabase. We also always use a DAC. I personally prefer the Sophia, but Navian works as well. And we can use any microcatheter we like, for instance, Prowler, Headway, and standard guide wires as you prefer. Our results in these aneurysms here with a very low dome to neck ratio and aspect ratio, some of these are down to 0.8 in aspect ratio actually. Immediately after the procedure, we have this image. It's a Raymond Roy score 1. We have 5 in this group 2, 9, and 9 in group 3. At 11.5 months later, we had this pattern here with 95% of the cases in group 1 and 2, meaning that they are satisfactorily occluded. This is the very difficult aneurysms. If we compare them to the more favorable group, we can see it's exactly the same pattern. And this is because the eCLIP, it doesn't care about the aneurysm anatomy. It's just a matter of how big the neck area is. If we compare the eCLIP results with the ones I have found about web and contour, we see here that after 16 months follow-up, we have only 4% of the patients in Raymond Roy group 3, compared to the web and contour trials here, where there were 21% in group 3. So in conclusions, the eCLIP has effective flow diversion effect, enables good and effective coil support, and in our material, we saw an occlusion grade that remained unchanged or even better at all follow-up time points. And so far, we have seen no recurrences. There's a learning curve, of course, using the device as we see with other advanced devices. In our center in Aarhus, Denmark, we have now treated more than 20 aneurysms with eclipse, both primary coiling and recoiling after web and other coil aneurysms. no recurrence so far, and as mentioned, improvement in modified ranking Roy score over time. This is what I want to show you. So, and thank you for your attention.
Thank you very much, Leif, for this presentation and the impressive results as well on this device. So I still do not see any question in the chat function, but now I know why I do not see any questions, because I just heard that this function is not active. But anyway, you can mail to, I'm not sure if you can see that. Yeah, that's not the way it works. But you mail to the BALT, you can mail your questions to the BALT people at marketing.point or marketing.germany@baltgroup.com, or just talk to them, and then they try to handle these questions to the speakers. I think that's the only way today that it works to stay in time. So thanks again, Leif, and all the other colleagues that they had very perfectly stayed in time. It's 8:45, so I think we are ready to close the symposium, but I think I can summarize that there are many ways to roam to solve a complex aneurysm. René tries or prefers to use a balloon. Sometimes I know he prefers 2, 3, 4 balloons with perfect results. Thomas presented very impressive results, like Leif as well, on intrasaccular and extrasaccular flow diversion. I think we can consider the eclipse, at least from the effect it works, or the way it works as a flow diverter. Leif, is that correct?
That's perfectly correct. And I think because we don't see these recurrences, it's only because we add this flow diversion effect to the coil retention.
Okay, so that's also my impression over the years I follow this device. I think there is still some room for providing more evidence on contour and eclipse, for sure.
That's true, and we are at the end with a trial where we are doing it more, what shall I say, more scientifically. So it will come within a short time, and we are still collecting data, of course, for a more broader experience with this. That's true.
And finally, we have the Leo stent portfolio, Leo baby especially, where I think the evidence is very broad. And now I would close the session. Thanks again for presenting to the speakers and for our large audience I see here. And enjoy the rest of the Congress and the weekend. Thank you very much. And again, thank you for BALT for offering this symposium, and a take-home point for BALT to invest in studies providing broad evidence on their large portfolio, even the new devices. Thank you very much.